Hello and welcome to our webinar on HIV screening and pre-exposure prophylaxis. My name is Jennifer Boniface and I am one of the nurse analysts with the Provider Outreach and Education team. Today's webinar will focus on the clinical aspects for the Medicare preventive services of HIV screening and pre-exposure prophylaxis. On this slide, you'll see a list of acronyms used in this presentation. During the presentation, if there are any acronyms you're unfamiliar with, please take a look at this slide for the definition. Before we begin, I want to point out the disclaimer at the bottom of the slide. By remaining on the webinar, you are agreeing to comply with the terms outlined in the disclaimers at the end of the presentation. So let's begin. World AIDS Day is recognized every year on December 1st. Regular HIV screening is essential for early detection, allowing timely diagnosis and treatment before the infection progresses to AIDS. HIV pre-exposure prophylaxis, or PrEP, is an effective prevention tool that greatly lowers the risk of HIV infection in HIV-negative individuals who are at an increased risk of exposure. Medicare covers a wide range of preventive services, including HIV screening and PrEP, to support the health and well-being of its beneficiaries. HIV screening and use of PrEP are essential parts of preventive care, particularly for individuals at higher risk of contracting HIV or for those who meet specific screening criteria. Our objective for today is to provide an overview of the clinical aspects for the Medicare preventive services of HIV screening and use of PrEP. We will cover background information about HIV, treatment options, HIV testing methods, and Medicare Part B coverage criteria for HIV screening and PrEP. Let's begin by looking at some key facts and statistics about HIV. By the end of 2024, approximately 40.8 million people worldwide were living with HIV, with around 1.3 million new infections and an estimated 630,000 deaths from HIV-related causes that year. The Centers for Disease Control and Prevention reports that in 2023, approximately 1.2 million people in the United States were living with HIV, with over 39,000 new diagnoses reported during the year. Globally, 87% of people living with HIV were aware of their status in 2024, meaning that 13% remained undiagnosed. This highlights the importance of early HIV screening, as it allows for timely detection of the virus, ensures quicker access to life-saving treatment, and plays an essential role in preventing its spread. HIV is a retrovirus that weakens the immune system by targeting the body's infection-fighting cells. It is primarily transmitted through direct contact with certain bodily fluids from a person who is HIV positive and has a detectable viral load. These fluids include blood, breast milk, semen, preseminal fluid, vaginal secretions, and rectal fluid. HIV transmission can occur through sexual activity, injection drug use, or from a mother to child during pregnancy, childbirth, or breastfeeding. HIV progresses through three main stages. The first stage is acute HIV infection or primary infection. During this stage, HIV rapidly multiplies and spreads throughout the body, targeting and destroying the CD4 T cells of the immune system. The viral load in the blood rises significantly, increasing the chance of HIV transmission to others. Flu-like symptoms may develop in the person 2 to 4 weeks after the virus infects the body. This stage can last from a few days to several weeks. Symptoms may resemble those of the flu and can include fever, headache, cough, sore throat, mouth ulcers, muscle aches and joint pain, swollen lymph nodes, rash, weight loss, night sweats, fatigue, and diarrhea. However, not all people in this stage will experience symptoms. Starting antiretroviral therapy during this stage may help with slowing down the disease progression. The next phase is chronic HIV or clinical latency. In this stage, HIV continues to replicate, but at a much slower rate. Individuals may not experience any symptoms, but the virus is still active and can be transmitted to others. Without treatment, This stage may last several years. If ART is not started, the infection will eventually progress to AIDS. The last stage is AIDS, or acquired immunodeficiency syndrome. At this point, the immune system is severely compromised and the body can no longer effectively fight infections or certain cancers. This leads to the development of opportunistic infections. Some common symptoms of an opportunistic infection related to AIDS may include recurrent fever, chills and sweating, swollen lymph nodes, rapid weight loss, white spots or lesions on the tongue or in the mouth, rashes on the skin, lethargy and weakness, and persistent diarrhea. Examples of opportunistic infections that can occur in those with AIDS may include bacterial infections such as tuberculosis, Mycobacterium avium complex, and Salmonella infection, viral infections such as cytomegalovirus and herpes simplex virus 1, fungal infections such as candidiasis and pneumocystis pneumonia, and parasitic infections such as toxoplasmosis. A person is diagnosed with AIDS when their CD4 cell count drops below 200 cells per cubic millimeter, or they develop one or more opportunistic infections. Without treatment, the average life expectancy after an AIDS diagnosis is less than 3 years. So who is at risk for HIV? Per NCD 210.7, Screening for Human Immunodeficiency Virus Infection, Medicare defines certain populations as being at a higher risk for HIV infection, including men who have sex with men and women who have unprotected vaginal or anal intercourse, past or present injection drug users, men and women who exchange sex for money or drugs or have sex partners who do, individuals whose past or present sex partners were HIV infected, bisexual, or injection drug users, people who have acquired or requested testing for other sexually transmitted infections, people with a history of blood transfusions between 1978 and 1985, those who request an HIV test despite reporting no individual risk factors, people with new sexual partners, and individuals who, based on individualized physician interview and examination, are deemed to be at increased risk for HIV infection. The assessment of an elevated risk of HIV infection is determined by the healthcare provider when viewing the patient's medical history. This evaluation is a routine component of a comprehensive medical history, often conducted during an annual wellness visit, and plays a crucial role in formulating a comprehensive prevention strategy. The medical advice given should align with the care provided, and the link to NCD 210.7 has been placed on the resources slide at the end of the presentation for you to review. Additionally, certain groups may be at increased risk for HIV infection, including individuals who have received unsafe injections, unscreened blood transfusions, organ or tissue transplants, or undergone medical procedures involving unsterile cutting or piercing instruments, as well as healthcare providers or others who have experienced accidental needle sticks or other similar workplace exposures. Now let's explore the treatment options available for individuals living with HIV. HIV is treated using antiretroviral therapy, which works by suppressing the replication of the virus and helping to reduce the viral load in the body. ART involves taking a combination of medications daily to treat HIV. These medications can be taken either orally or through injection, depending on the treatment plan. When taken consistently and as prescribed, ART can significantly reduce mortality and morbidity rates associated with HIV by protecting the individual's immune system, reducing the amount of HIV in the body, reducing the risk of transmission of HIV, and preventing HIV from progressing to AIDS. Individuals living with HIV who maintain undetectable viral loads have an extremely low risk of sexually transmitting HIV to their HIV-negative partners. This concept is known as U equals U, or undetectable equals untransmittable. ART also plays a crucial role in extending the life expectancy of individuals living with HIV. It is a lifelong treatment that must be taken consistently and without interruption. Even when the viral load is undetectable, it's important for those living with HIV to continue their antiretroviral therapy. There are two types of preventive medications designed to help reduce the risk of HIV in individuals at high risk of contracting the virus. Pre-exposure prophylaxis is the medication taken to help reduce the risk of contracting HIV for those who are at a greater risk for this. Individuals must be HIV negative to start PrEP. When taken as prescribed, it's considered highly effective in preventing HIV. Post-exposure prophylaxis is the medication given for the prevention of HIV after a possible exposure. PEP needs to be started within 72 hours following a possible exposure to HIV. It is also considered highly effective in preventing HIV if taken within this time frame. According to CMS's resource, PrEP for HIV, National Coverage Determination, Technical Frequently Asked Questions for Pharmacies, pharmacies must include at least one valid ICD-10-CM diagnosis code on claims submitted to Medicare Part B. Examples of diagnosis codes can be found on MLN 006559 Medicare Preventive Services chart under HIV PrEP. You can find a list of codes as well as additional information regarding PrEP on CMS's webpage PrEP under the section What Diagnosis Codes Can I Use? Links to all three of these resources are located on the resources slide at the end of the presentation. CMS covers the use of FDA-approved antiretroviral drugs for PrEP to help prevent HIV in individuals at high risk of infection. This coverage includes the dispensing and supply of both oral and injectable PrEP medications, as well as the administration of injectable PrEP. Healthcare providers are responsible for evaluating a patient's history to determine the risk for HIV and eligibility for PrEP. For individuals being evaluated for or currently taking PrEP, CMS provides coverage for up to 8 individual counseling visits within a 12-month period, including an initial or continued HIV risk assessment, HIV reduction strategies, and medication adherence. Counseling must be conducted by a physician or other qualified healthcare professional, and the patient must be competent and alert during the session. In addition to counseling, CMS covers up to 8 HIV screening tests every 12 months and 1 screening for hepatitis B virus. These screens are covered when performed using FDA-approved laboratory or point-of-care tests that comply with FDA labeling and Clinical Laboratory Improvement Amendments, or CLIA, regulations. There is no copayment, coinsurance, or deductible for PrEP for HIV and its associated preventive services. Both HCPCS codes G0011, individual counseling for pre-exposure prophylaxis by physician or qualified healthcare professional to prevent human immunodeficiency virus 15 to 30 minutes, and G0013, individual counseling for pre-exposure prophylaxis by clinical staff to prevent human immunodeficiency virus, are telehealth eligible. So both G0011 and G0013 are telehealth eligible. For more details, please refer to NCD 210.15, pre-exposure prophylaxis for human immunodeficiency virus prevention. And a link to this NCD has been placed on the resources slide at the end of the presentation. The only way to confirm whether a patient has HIV is through proper screening for the human immunodeficiency virus. This is why it is crucial to identify individuals or groups at risk so appropriate screening and counseling can be offered. Early detection through screening can lead to early treatment and in turn allow those living with HIV to lead longer and healthier lives. Per NCD 210.7, CMS has determined there is sufficient evidence to support HIV screening for all individuals aged 15 to 65 as recommended with a grade A by the USPSTF. This screening is considered reasonable and necessary for early detection of HIV and is appropriate for individuals eligible for benefits under Medicare Part A or enrolled in Medicare Part B. The U.S. Preventive Services Task Force has assigned a grade rating of A for the recommendation of HIV screening for certain individuals, and we'll discover coverage details and discuss them when we review the Medicare coverage criteria. A grade A recommendation from the U.S. Preventive Services Task Force typically indicates a high level of certainty that the benefits of the service outweigh the potential harms. CMS requires a USPSTF rating of either A or B for coverage of a preventive service. However, it is important to consult the latest official documents or updates from CMS or the U.S. Preventive Services Task Force to ensure you have the most current and accurate information, as policies and recommendations may change over time. So let's discuss the Medicare coverage criteria for HIV screening in more detail. Medicare Part B covers HIV screening for certain beneficiaries, regardless of perceived or increased risk, including those who request the test or are pregnant. It's important to determine whether a patient is eligible for coverage before billing Medicare for HIV screening. Medicare Part B coverage applies to individuals between the ages of 15 and 65 without regard to perceived risk, those younger than 15 and adults older than 65 who are at an increased risk for HIV infection, and pregnant women. Medicare does not cover HIV screening for certain beneficiaries. This includes people who have a known HIV-related illness. It also excludes those between the ages of 15 and 65 who've had an HIV test within the past year, as well as individuals younger than 15 or older than 65 who are at an increased risk but have also been tested within the last year. In these cases, Medicare will only provide coverage for subsequent screening if it is performed at least 11 full months after the month of the previous test. Lastly, pregnant women who've already had 3 specific screening tests during each respective term of pregnancy are not eligible for additional covered tests. Medicare provides coverage for voluntary HIV screening annually for patients ages 15 to 65, regardless of perceived risk, annually for patients younger than 15 and adults older than 65 who are at increased risk for HIV, and up to 3 times during pregnancy, including at the time of pregnancy diagnosis, during the 3rd trimester, and at labor if ordered by their healthcare provider. There is no copayment, coinsurance, or deductible for HIV screening as long as the healthcare provider accepts assignment. Now let's take a look at the types of HIV screening tests that are covered by Medicare. Medicare covers both laboratory-based and point-of-care HIV screening tests as long as they are approved by the U.S. Food and Drug Administration. To qualify for coverage, these tests must be used according to FDA-approved guidelines and must comply with the regulations outlined by the Clinical Laboratory Improvement Act, or CLIA. Medicare coverage applies when HIV screening tests are ordered in a clinical setting by a healthcare provider who's authorized to submit claims for reimbursable services, and the tests are performed by a Medicare-approved provider. There are 3 types of tests used for screening for human immunodeficiency virus that we will discuss today. The first type of test we will cover is the antibody test. These tests detect antibodies in a person's blood or saliva that are produced in response to an HIV infection. Antibody tests typically detect HIV 23 to 90 days after exposure, depending on the individual and the type of test used. Usually, HIV detection through antibody test using venous blood occurs sooner after infection than tests conducted with fingerstick blood or oral fluid samples. The second type of HIV test we will discuss is the combination of 4th-generation antigen antibody test. These tests detect both HIV antibodies and antigens. After exposure to HIV, the immune system begins to produce antibodies in response to the virus. Antigens are foreign substances that trigger an immune response. During the early phase of HIV infection, an antigen known as P24 appears before the antibodies become detectable. Antigen antibody tests are typically performed in a laboratory using blood drawn from a vein. A rapid antigen antibody test can also be performed using blood from a finger stick. Antigen antibody tests using venous blood typically detect HIV within 18 to 45 days after exposure. When performed with fingerstick blood, detection usually occurs within 18 to 90 days after exposure. The third and final type of HIV test we will discuss is the nucleic acid test, or NAT. Nucleic acid tests detect the genetic material of HIV in the blood, allowing for identification of the virus itself. This test should be considered for individuals with recent or potential HIV exposure who are showing early symptoms but have tested negative on antibody or antigen antibody tests. Nucleic acid tests typically detect HIV within 10 to 33 days after exposure, and a detailed list of FDA-approved HIV tests can be found on the CDC website. A link to that resource has been provided on the bottom of this slide. Confidentiality with HIV testing should follow the same strict standards as with all patient information. Confirmed HIV-positive health results should be reported to the local or state health departments to track the spread of the virus and monitor HIV prevalence and incidence. Health departments remove personally identifiable information before sharing de-identified data with the CDC, and the CDC uses this information to develop prevention strategies and guide policy decisions. The CDC does not share any personally identifiable information. Screening for HIV should be voluntary. It should only be performed after obtaining either verbal or written consent from a patient with accordance with applicable state laws. Patients should receive basic education about HIV screening before testing occurs. This education should include an explanation of HIV infection, definition of positive and negative test results, opportunity for the patient to be able to ask questions and have them answered, and ability for the patient to opt out or decline testing. Patient consent for HIV screening should be obtained using the same general informed consent form used for other medical tests. Using a separate consent form solely for HIV testing is not recommended. If a patient declines an HIV test, this decision should be clearly documented in their medical record. Documentation for HIV screening and PrEP, if applicable, should include date service was provided, signed and dated physician or qualified non-physician practitioner order for the laboratory services to be performed, confirmation that the patient provided informed consent, type of HIV test performed, test results and documentation of any follow-up care and/or counseling that was given following evaluation of results. If applicable, documentation of counseling intervention for PrEP was provided by a Medicare-eligible physician or other qualified healthcare provider, and the patient was alert and competent during counseling sessions, and documentation to support medical necessity of HIV screening and use of PrEP. Ensure all documentation is dated and signed with the provider's credentials. Prior to completing these HIV-related preventive services, ensure your patient has met the eligibility and frequency criteria for coverage. Early detection and treatment in individuals living with HIV can significantly lower the risk of progression to AIDS and other immune-related complications, helping them to live longer, healthier lives. During today's webinar, we provided background information about HIV, discussed treatment options, including medications used for both HIV prevention and for managing HIV infection, explained the different types of HIV screening tests covered by Medicare, and reviewed the Medicare coverage criteria for HIV screening and PrEP. And I've included some resources on the next few slides. They contain links to some of the information we discussed today. The first slide includes links to NCD 210.17, Screening for Human Immunodeficiency Virus Infection, and NCD 210.15, Pre-Exposure Prophylaxis for Human Immunodeficiency Virus Prevention, as well as MLN 006559, Medicare Preventive Services Chart for HIV PrEP and HIV screening. The next slide provides links to additional CMS resources, including the Medicare Claims Processing Manual, Chapter 18, PrEP for HIV and related preventive services, and PrEP for HIV National Coverage Determination, Technical Frequently Asked Questions for Pharmacies. It also contains links to HIV.gov clinical guidelines and the U.S. Preventive Services Task Force recommendations for HIV screening. And just a quick update, the webpage PrEP for HIV-related preventive services has been renamed by CMS to PrEP as of November 17, 2025, and the link on the slide will still take you to the correct webpage. The final slide includes a WPS article on screening for human immunodeficiency virus and the encore presentation for billing HIV screening. Please refer to these slides and use them as a reference when reviewing the presentation. So we are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions in the chat. And I'm just going to quickly review the chat. And I don't see any questions at this time. But if we do have any questions, or if you do have any questions, please put it in the chat, and I'll take a look at the chat before we finish up this webinar. Please take a moment to complete a survey and share your feedback. We use your feedback to develop topics for future education. You can access the survey by either clicking the link in the chat or by visiting the CMS Qualtrics page after the webinar. CMS is reminding providers that participating in Medicare offers several benefits, including receiving the full physician fee schedule amount, direct payment amount for Medicare, and automatic forwarding of claims to Medigap insurers. All providers must decide their Medicare participation status for 2026 by December 31st, 2025, though no action is required if they plan to keep their current status. And for more information, please review the CMS Annual Medicare Participation Announcement, and it is hyperlinked on this slide. So I do not see any questions, so we're going to finish up this webinar and give you some time back in your day. So in a few minutes, you will receive an email thanking you for attending, which includes your certificate of achievement and a link for the survey. If you need contact hours for continuing education, they will also be in the email. If you don't see it, check your spam folder. If you called in, email us at wps.gha.education@wpsic.com with the webinar name and phone number, and we will send you your certificate of achievement. And all these announcements are on the bottom in the notes section of the slides. If you think of any additional questions after today's event, you have 7 days from today to submit them. Send them to our education mailbox, again at that email address, wps.gha.education@wpsic.com, and put the title of this webinar in the subject line. However, if you have any claim-specific questions, please direct those questions to our customer service department, as we don't have access to your claim information and are therefore unable to look up your claim. Also remember, we cannot accept any type of PHI or PII via email. Finally, on behalf of Mary Sue, myself, and all of Provider Outreach and Education, thank you for attending today's webinar on HIV screening and PrEP. As a reminder, this presentation will be posted as an encore presentation on the Training Center page on our website. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect.